Nat, what was the situation of Chinese healthcare a couple of years ago?
Well, we in 2007 we did a study. It was called Diagnostic Cost for the Developing World, and we traveled throughout China to some of the poorer areas of China. And what we really discovered is that essentially there was no medical care for the poor in the remote areas of China. That the health care was exclusively in the cities and in the Class 3 hospitals. I probably have mentioned before that the hospital class situation set up by the Ministry of Health back in the early 80s was for three class levels of hospitals. There was the Class 1 hospital that was supposed to be the entry level, and they control prices. The government established prices such that the general public, the poor, could afford to get their care from those Class 1 hospitals. Then slightly above that were Class 2 hospitals that were more of a referral for the next level. And then above that was Class 3 hospitals. And the structure they set up was for pricing at the Class 1 hospitals, as I said, to be accessible for the common people. Class 2 hospitals could be a little higher than that, and Class 3 hospitals could be much higher than that. So there were different levels of cost that the hospital was allowed to charge the patient or to charge any company insurance policies or for government workers. The result of that was that the Class 1 hospitals were not generating enough revenue to even cover the costs of the procedures that they were doing. So essentially what happened is the Class 1 hospitals, I would say about half of them went bankrupt. The doctors couldn't be paid anymore, and so they left to become salespeople for drug companies or do something else. And so the situation became quite desperate, even in the cities, where no one would go to a Class 1 hospital because they knew they couldn't get any kind of quality care there. And so what happened is everybody, when they first had a headache or a cough, they would jump right to the Class 3 hospitals. So the result of that is the Class 3 hospitals became overburdened with the number of patients they had. But on the other hand, they generated so much profit there that when you visit some of these Class 3 hospitals, they are some of the most well-equipped hospitals and sophisticated hospitals in the world. But the contrast to that is as you go down the levels, you run out of effective health care very quickly outside those Class 3 hospitals in the major cities. When you go outside the cities to the rural areas, what we found is that it was very difficult. For example, diagnostics in the village clinic level is restricted to a thermometer, a stethoscope, and possibly a mercury barometer with a cuff. And that's all they have to diagnose anything out there. So, and some of these villages are not that close to a city either, so that it's not like you can. In fact, we ran into cases where the patient might be told, I think you have something more serious, like you look like you're going to die in the next couple of days. Why don't you hop on the bus and go to the city? He said, I don't have enough money to pay for the bus. So essentially, what was happening is in the countryside, those people and their children were not getting very common care that the people in the cities were getting. So I think the Chinese government recognized that they had a real problem, and that the healthcare system, both in the cities and even worse in the countryside, that healthcare system was broken.
So the issue was inequality and lack of access, and the central government stepped in and said we're going to do a healthcare reform. And what's the situation of that reform today?
Well, let me add one other thing there, and that is that back in the early 80s, hospitals, healthcare was marketized. Prior to that, it was strictly social, a universal healthcare system. And so what happens is the government really doesn't sponsor, they don't pay for these hospitals. These hospitals, no matter what level they're at, down to the village clinic even, they have to generate revenue themselves, and they have to generate profits themselves. And so the other thing that came out of this was that those procedures and those drugs that were very profitable for the hospital got prescribed whether they were needed or not. If you went into a Class 3 hospital and you had a headache, you'd get an MRI because there was a lot of profit in the MRI. And you'd walk out of there with a bag of drugs that you may or may not need. And even when you entered the hospital, you would get hooked up to an IV. Even if it was an antibiotic that you could buy in a pharmacy in a pill form, they'd make sure you get it in an IV so you didn't go there and buy it. And they wouldn't test to find out whether it was a virus or a bacterial infection. They just give you the the antibiotic for the bacterial infection. So, that's just another part of what was recognized as a problem, and prescriptions were grossly misused. So part of healthcare reform now is to try to control that a little bit better, so that recognizing that drugs have been grossly overprescribed. To me, in the IVD business, that's one other driver that's going to help IVD, and that's that the hospitals are going to have to demonstrate that you really have that problem before they give you the drug for it or sell you the drug for it. So that's part of healthcare reform. Healthcare reform was $125 billion at that time with the exchange rate, $125 billion US dollars incrementally to be put into the healthcare system. Some of that was for updating some of these lower level hospitals, upgrading them, and getting those hospitals equipped. And some was also to expand the healthcare coverage, so that more people were covered, and that the depth of coverage was more, and that's continuing. How well that was implemented in some of the richer areas, I think. Well, I may have mentioned before that the 125 billion. What most people don't understand is only 30% of that was going to be supplied by the central government. The other 70% had to come from the local governments, and so those governments who could raise that kind of money with taxes to be able to afford that were able to implement a lot of this. But still, some of the poorer areas in Yunnan province, for example, or out in the west, implementation still has been very, very slow. But that healthcare reform was for 2009, 2010, and 2011. So people say, well, what's going to happen when 2011's over? That program's over. But anyone who's been keeping up with this new Congress, who are developing the 12th five-year plan, that 12th five-year plan is heavily weighted still in the social system and in improving healthcare. And so there's going to be a lot of money spent in the 12th five-year program as well, on healthcare improvements and broadening the insurance system.
So with regard to healthcare reform and the situation that it is in right now, what's the degree of technology penetration, for example, in the Class 1 hospitals now?
Well, many of the Class 1 hospitals have been converted over to now to something called community health centers. And those community health centers that we visited are, in many cases, they're more modern, they're clean, they have some reasonably nice equipment, although lower level equipment. They're not the 2,400 tests per hour. In many cases, we find chemistry analyzers that are 400 tests per hour in a hospital that has 35 beds and there's only 3 patients there. So a bit of it might be overkill, but these community health centers, they've really been doing a good job converting. There's one in my neighborhood used to be an elementary school, and they've converted it over to community health centers. They're still having trouble attracting patients there, though, because the patients still don't believe that the healthcare there is as good as they can get if they go to a Class 3 hospital. So I guess the bottom line is it's been progressing. They've been spending the money. I have some friends in these Class 3 hospitals who now are spending some of their time going out to these other facilities and doing training. And that's another factor that's helping our IVD, is that the IVD business, is that they are now going out there to train people on why they need to order this test. Why, when somebody comes in with these symptoms, this is what you have to do to be able to recognize and treat that condition. One of the, we work very closely with AACC, who's next door here, and AACC has implemented a program in China, translated into Chinese. Some of my friends have been the editors who have been doing that. It's called Lab Tests Online. And there they can look up in Chinese any kind of a condition, and they can see what recommended tests should be done, what those tests mean, what's important in drawing the sample and storing the sample, and all that educational material that's now going to be online for some of those people as well. So I think in terms of where we are now on healthcare reform, there's a lot of money been spent. As I have been saying, I think certainly the IVD business, and probably in general, the IVD business has been growing by more than 30% per year in the last 3 years in China.
So talking about education levels and staff, what is point-of-care testing doing to help with regard to this?
Well, I think certainly anything that's more user-friendly and doesn't require a lot of education to be able to do, and maybe doesn't need to be as automated and can be more of a point-of-care test, has seen growth and will continue to see huge growth. And we visit most of the companies here, and there are more than 200 that we track, IVD companies, and rapid test manufacturers have been expanding like crazy. And that's because those rapid tests are very easy to use, they're disposable, you don't need to invest in a big machine. And so those have seen tremendous growth. And then other point-of-care instruments, smaller instruments, maybe more dedicated instruments. For example, when you get outside into the township level hospitals and somebody comes with chest pains, you don't know whether they're having a heart attack or not. And you probably don't have the time to send the sample or send the patient way into the city to do some further testing. So some of these markers, cardiac markers, that are now point-of-care cardiac markers are important. So if you look at the kinds of things that people come into those clinics for, and you look at if there's some products that are reasonably low cost and rapid and easy to use, that's, I think, where the bulk of the market has gone and is going to go even more in the future.
What about the digital flow of information?
Well, that's another important thing, I think, and I'm not so sure how quickly that's being implemented. And one of the issues always is how we're going to pay for it. But there are many people high up in the government who have recognized that the importance of being able to, in real time, transmit data so that more educated people that might be in the city can participate in the treatment of the patient and the recognition of the condition of the patient. So I think for any company who's thinking about point-of-care tests, it's absolutely essential that they have some kind of probably two-way communication and real-time online feed. We just sat in recently on Johns Hopkins University, who does an awful lot in the U.S. and in other parts of the world with this interconnectivity, and they were talking about even things like somebody comes in with a rash. You don't know what that rash is, but if you have a digital camera and in real time you can not just take a picture but a video that gets transferred up, and on the other end they say, well, can you move it over to the left a little bit? Let me take a look. Can you get closer to it and look at that? And they can then diagnose probably what that rash is caused by and what the treatment should be.
What's going to be the influence of the law that says that physicians can now make private money?
I think that's a huge change. I think in the past, people, the doctors and the people in the clinical laboratories were not allowed to generate any income from anywhere else but the salary they got in that facility. Unfortunately, they found ways to get other income, but now, on the one hand, maybe it'll keep some good doctors from becoming drug salespeople, which many of them do, and instead be able to generate some income from being consultants for some of these lower level hospitals, the community health centers, and as I said, some of these remote locations where they can be the advisor.
What are the lessons to be learned from China?
Oh, I think lessons for, let's say lessons for the U.S., which is where our other office is. I'm concerned in the U.S. that we don't have very good health care for the poor, and probably getting worse. And I tell some of my conservative relations there that I'm surprised to see that they want to pattern our healthcare system after China's, because China now is strictly a capitalist healthcare system, and those people who can afford good healthcare can get good healthcare, but those people who can't really suffer. So I think the Chinese government has recognized that, and they're working on some programs to try to improve that. And I think hopefully we'll continue in the U.S. to work in that direction as well, so that our healthcare system is a more fair system. The other thing I guess I want to mention is that the Chinese government has also recognized that they have been too dependent on exports and that they need to generate internal consumption, and they've been working on programs to generate internal consumption. One of the things that keeps the savings rate here in China so high, and despite the fact that this is such a poor country, China has about a 20% savings rate, and it's the highest in the world. And the reason for that is because they don't have these social safety nets, that everybody tucks some money under their mattress just in case somebody in the family gets seriously ill. They have to be able to pay a lot of money to keep that person alive. And so that's a lot of it. And then the other thing is the pension system as well, is that the older people, they're depending on their children to take care of them later on in life. And so there's a lot of savings that goes into that as well. And I think the government's recognized that if they can free up some of that by developing some of these social safety nets, a lot of that money's going to come out from under the mattress, and it's going to result in increasing the GDP internally here.